Hello and welcome. My name is Raj Persaud. I'm a consultant psychiatrist working in private practice, and I'm delighted to be joined now by Professor David Healy. Professor Healy is a professor of psychiatry at the University of Bangor, and he's published a very interesting paper, which we're going to be discussing in this podcast with some colleagues, Joanna Lemuri and John Giuradini, if I pronounced that correctly. And the title of the paper is Pediatric Antidepressants, Benefits and Risks. And this is published in the International Journal of Risk and Safety in Medicine. So, Professor Healy, many thanks for joining us. First of all, you start off the paper by talking a little bit about the dramatic rise in mental health problems in children, leading on to a dramatic rise in the prescribing of antidepressants for children. So let's talk a bit about that background first, about what's happening to the mental health of children and the prescribing of antidepressants to children.
Yes, well, I chaired a workshop for the BAP, that's the British Association for Psychopharmacology, 20 years ago. And at that point, the use of drugs for ADHD or for childhood mood disorders the use of any drugs acting on behavior or on the mind in children was extraordinarily rare within the UK. The reason we convened the workshop was because we were aware that things were changing, particularly in the United States, where the rise of ADHD in particular was a big issue. And we were trying to prepare the ground for the scene here in the UK. What was the basis, or when would it be reasonable to use any of these drugs for any of these conditions in children? And at that stage, the received wisdom was that children didn't get depressed. They certainly didn't get melancholia. They might get unhappy, they might be miserable, they might be out of sorts, but it's the kind of thing that talking to a parent and an adult therapist or whatever, someone who was older and wiser would be able to put right. This was not the kind of condition that we thought about turning to pills for. In the early noughties, around 2004, there was great concern about the use of the SSRI group of drugs, which have been used widely for adults who are depressed. There was great concern about their use for children, and there were a few programs on the BBC in particular about this, which led to the use of these drugs not taking off here in the UK the way it did in the United States. But in recent years, over the course of the last 5 to 10 years or so, it has taken off. And now the view is that close to 100,000 children in the UK are likely on one or other of the antidepressants. And this isn't including the other drugs that are used for mood disorders like the anticonvulsants or the ADHD meds. It's very hard to know exactly how many people are on these drugs. The pharmaceutical companies will have great information of every single drug in the group that's been given to every single person of all ages. That's not the kind of data that you or I can get access to. So it's hard to be absolutely sure what the true number is. The Centers for Disease Control in the United States seem to be happy to say that people over the age of 12 fall into the adult group as regards. So that if that's the case, then particularly for girls over the age of 12, the antidepressant group of drugs is probably the most commonly used drugs in the United States, barring the oral contraceptives. And the rate they appear to be increasing here seems to be leading us to a comparable kind of situation here.
So that's a really striking idea that for young girls, adolescent girls, setting aside the oral contraceptive pill, or maybe including it, antidepressants are becoming the most prescribed drug, both in the US and in the UK.
Yes, that's correct.
And that naturally leads on to a question which you're kind of posing in the paper, which is, what is the research evidence that it's a good idea to prescribe antidepressants, that they're effective? Would it be fair to summarize that that's the question you're trying to address in this paper?
Yes, it is. That's the key issue. And it's extraordinarily curious because most of the drugs being used are not on patent. So the pharmaceutical companies that actually produce these drugs don't have a tremendous incentive to get out there and flog them to kids under the age of 21 or so. So the increase is coming more from that there seems to be a changed from the way things were 20 years ago, where we wouldn't have thought about giving these drugs to young people, to greater openness to the idea that, yes, maybe we should. And that may be born from the experience of general practitioners giving these drugs to adults. If they give them out to people in their 20s, 30s, 40s, 50s, and they figure they work, they may be thinking, well, perhaps they also work for this age group too.
Or there's an alternative, darker view, which is that the GPs are a bit stuck with what to do, and they are, if I can use this pejorative term, palming patients off or children off with these drugs, because in the world of mental health, sometimes if you just get someone out of the room, nothing terrible, too terrible is going to happen. And it's the way a GP has of handling this problem without opening, quotes, a can of worms. So there's a darker interpretation that they're at best doing no good at all, but just getting people out of the room.
Well, I'll frame that in perhaps in a slightly different way, which is this. For the most part, I think GPs are extremely good. They're very good doctors. There is a risk that the general culture in which both they operate and we operate has become much more of a quick fix culture, so pills are useful for that. But the other factor here is that the articles on the antidepressant group of drugs, this group of drugs given to children, does say that they work. The articles conceal the hazards. The NICE guidelines say you can use these drugs. They do say, look, the use of these drugs should be restricted to people at young people who are reasonably severely depressed. But on the other hand, if they work for people who are reasonably severely depressed, and if they don't come with great hazards, and certainly the NICE guidelines don't talk about the hazards, then they're probably going to work for people who are less severely depressed also. So there's a bit of a downward slope there for general practitioners to slip on and to say, well, look, there isn't any great reason why I shouldn't be using the drugs. And I think it's that no great reason not to use the drugs that's tending to lead to their increased use.
Okay, now I want to just do another background point, which I think is important, which is the very word antidepressant seems to suggest that the drugs are directly tackling depression. They've got some handle on the mechanism, the brain mechanism underlying depression. And the problem is, and again, you're the expert, that's not really the case. The drugs produce an effect on people, but that isn't a specific kind of like antibacterial targeting effect like antibiotics do, whereby we know what causes depression, and we've created drugs that target the thing that causes depression. So the very word antidepressant is a bit problematic. I don't know whether you'd agree with that.
Oh, yes. Yeah, no, sure. And the key thing is, I think, with the marketing of this group of drugs, what came with it was a bit of a myth, which was the idea that the serotonin system is out of whack in the case of people who are depressed. And what these drugs do is to put that right. And that just isn't the case. There's no evidence that there's anything wrong with the serotonin system in any people who are anxious, depressed, or whatever. The drugs certainly do work on the serotonin system, but their action on the serotonin system wouldn't work if the serotonin system wasn't working properly. And what their action does is produce a degree of emotional numbing. They make you if we get the right dose and if we get the right drug for the right person, they can make you more serene. But they're not curing the illness. If actually making you a little bit more emotionally numb isn't the kind of thing that's going to help solve the problems you've got, then these drugs aren't going to be helpful. If this kind of effect is one that doesn't appeal to you, then the drugs as such aren't actually going to be helpful, and it'd be much better to get you off them than to leave you on them.
Now, the word emotional numbing you use in the paper, and it's interesting because actually psychiatrists often then get to read a proper in-depth analysis of what the drugs actually do, really. So I thought it was a very interesting phrase. But my experience as a psychiatrist is they are a group of patients who do want this emotional numbing. They wouldn't call it that, but they do come back to the clinic and say they've had a positive experience from having the drug. And they do say something. They wouldn't use that term emotional numbing. They would kind of say, I'm less upset, something like that, maybe. I mean, so is it not the case they are a group of patients that want or desire or benefit from this emotional numbing experience, as you put it?
Oh, yes, sure. And it's just like the fact that if we give alcohol to people, there's a group of people who will actually be helped by alcohol. And the key thing in terms of a doctor here, you know, if you're a good doctor, you can use alcohol to get some people well, but key to being able to use alcohol well as a doctor is being able to know when not to use it, or when you see the effect it has on the patient you've given it to, knowing when, well, in the case of this patient, it isn't working and we need to halt it earlier rather than keep on using it. It's very much the same thing with the SSRIs. If as a doctor you can't know, or you aren't able to use alcohol therapeutically, you're probably not going to be able to use the SSRIs therapeutically either. And that's the challenge. The giving of pills isn't ever just a doctor operating as a kind of a dispensing machine. They're therapists, and part of the therapy involves knowing when to use these drugs and when not to use them, being able to match the pill to the patient that you've got.
Now, that's a very important point I want to pick up on, because in my view, the way people think about these drugs is that the drug, just that the handing over of the drug cures the patient. But I believe that these drugs in particular require a kind of monitoring, a kind of supervision, which is a large part of why they work. So the other thing that happens in general practice is you get the drug and you disappear. You don't come back for about a month, and then you disappear. You don't come back for another 3 months. So the level of supervision isn't right. The other thing that happens is that people don't adjust the dosage enough, in my view. Often it's too low a dose or too high a dose. But the responsiveness of adjusting the dosage to the patient's experience lags way behind, is too slow. And sometimes patients only need the drugs for a very short period of time, and sometimes they need it for a long period of time. So the kind of flexibility is needed. So again, you're the expert in this. I'm just the kind of jobbing practitioner. My view is that the drugs require skilled supervision, and that is often sadly missing. What are your thoughts?
Well, no, I think I differ a little bit. First of all, key to actually being able to monitor is, you have to be told what to monitor for. You have to be told, look, the effect we're trying to produce with this drug is to make the patient somewhat more emotionally numb. And this has to be the kind of thing that they find helpful. So in order to monitor, in order to be able to keep an eye on that, I need to be able to tell the person beforehand that this is what we're trying to do. And both they and I keep an eye on this. We also need to know that this can go very badly wrong. As opposed to the person becoming more relaxed and chilled out, they may become more agitated. They may become suicidal. We need to be able to tell people these are things that can happen too. We need to keep an eye on it, and we need to keep an eye on you fairly regularly, in order to see if this is actually happening or not. A lot of doctors, as you say, don't bring the patient back often enough. That's partly because they haven't been told that things can go as badly wrong as they can go. Now, if they were told that things can go badly wrong, then I think they would be bringing the patients back a lot more often. But it's the quality of the information doctors are fed that's part of the problem. The other part of the problem is this, and this is where I come a little closer to your point of view, I think, which is a good doctor is a person who engages with the patient that they have first, rather than the evidence base. If there's a mismatch between what you see right in front of you and what you hear from the patient and what the evidence base says, a good doctor is going to be listening and engaging with the patient first and trying to work out, well, how do we reconcile this with what the so-called evidence base is afterwards? Unfortunately, all too often, a lot of doctors, and it's not just general practitioners, it's actually, I hate to say it, consultant psychiatrists as much, if not more than anyone else, who go by the evidence base rather than the patient right in front of them.
Okay, that's very helpful. So the other quick thing I want to talk about before we get to the concerns the FDA have about these drugs in 2004, which you write about in the paper, is you talk about energy enhancing effects. You talk about the development of the SSRIs as being an attempt to do something about the energy enhancing effects of the older drugs and the anxiolytic effects of other older drugs. Can you say a bit about that? What do you mean by energy enhancing and anxiolytic? And what were the SSRIs meant to do?
Okay, well, the older drugs we had first came actually on stream during the late 1950s, and these were the tricyclic group of drugs, and they, as it turned out later, acted on both the noradrenaline system and also the serotonin system. And it's clear now that it's the action on the noradrenergic system that was energy enhancing. And a person called Arvid Carlsson in the late 1960s, looking at the group of drugs we had then, was interested by doctors saying, look, there's a group of drugs, there are drugs in this group that seem to be more energy enhancing than others. And then there's a further group of drugs in the group that seem to do something else as well. And this is a more anxiolytic type action. Carlsson was the one that put his finger on this and said, well, you know what, the drugs that do the more anxiolytic kind of thing, they also act on the serotonin system rather than just the noradrenaline system. So why don't we try and make a drug that acts on the serotonin system only and not on the noradrenaline system and see what that looks like? And that's what led to the first of the SSRI group of drugs, the selective serotonin reuptake inhibiting group of drugs. That kind of sounds like this group of drugs are going to be clean and free of problems. They're not. All it means is that they work on the serotonin system and the cholinergic system and the antihistamine system and a whole bunch of other systems. All they are selective to is the fact that they are selective away from the noradrenergic system, so they don't have the energy enhancing action that some of the older drugs did.
Okay, so you talk in the paper about the FDA becoming concerned in 2004. What were their concerns?
Well, the concern stemmed from a BBC program about the antidepressants and their use in children. And what the BBC found was that the evidence that the antidepressants worked as well as the clinical trials seemed to say they worked wasn't as good as it seemed to be. And the key drug that the BBC were concerned about was actually Seroxat. This has been given to children on the back of a clinical trial that had appeared in 2001, claiming that it worked extremely well for children and was very safe. Digging into that, what the BBC program found was actually the evidence was the drug didn't work all that well, and that a group of children who in the paper were being described as becoming emotionally labile, in fact had become suicidal. And when the digging went a bit deeper, it turned out that actually in the paper, they'd only reported half of the number of children that had become suicidal in the clinical trial. So this caused a crisis when all of this came out into the open, and had FDA over in the States and MHRA here to review the evidence base for this group of drugs generally being given to children, and finding that almost all the trials that had been done, even though they've been written up as positive trials, were actually negative. Now, the key drug, the interesting drug in the mix here, and this is the sensitive point, was at this point, Prozac had been approved for the use of children who were depressed, and FDA had claimed, well, you can only approve a drug if the trials are there showing that it has a positive action. And there appeared to, well, there were two published Prozac trials saying that this drug worked for children, and it was this that had led to the approval of Prozac. But in fact, in the case of the Prozac trials also, these are negative trials. So in fact, pretty well all the trials we have in this age group using the antidepressant group of drugs are all negative. This doesn't mean that you can't use these drugs for children. But it does mean that the companies shouldn't be promoting them for children. And it does make the issue about what groups like the NICE guideline groups say, it makes their job very complex.
Now, let's talk about this very thorny issue of suicidality. Why would these drugs seem to make children more suicidal in some cases, obviously not in every case, and not do that with adults? Or are we just seeing the same effect in adults, just in children? It's just getting a bit more attention. So there's an idea around in the literature that we should worry about these drugs and children and suicidality. But in the adult literature, I thought the worry was the reason why some adults are more likely to have a go at suicide when starting an antidepressant is their motivation levels go up ahead of their mood levels. So they're still feeling low, but they now have the drive to go and do something if they're feeling a bit hopeless and despairing. But again, what are your thoughts?
No, well, the issue is that this group of drugs in clinical trials that have been done, they make adults just as actively suicidal as they can make children. The difference in the children trials versus the adult trials is that in the adult trials, you can show the drugs have some benefit, but in the kids trials, you can't. So there's not a benefit you can put against the risk in quite the way that you can in the older age group. So this is what's led to a black box warning on the drugs for children, but not for older age groups. But the risk actually is the same. And on the point about do the drugs enhance your mood and therefore you're able to go out and kill yourself, the key point here is that if you give these drugs to healthy volunteers, that's people who aren't at all ill, you can make them suicidal also. So this is a direct action of the pills. If this group of pills don't suit you, whether you're clinically depressed or whether you're anxious or whether you're just a normal volunteer, you can become suicidal. It's nothing to do with them clearing up the underlying illness.
So people became very worried about this suicidality issue, as you put it, and you're putting the point in the paper that the benefit-risk ratio in kids suggests ever increasing, as you dig into the data, ever increasing problems with the drugs and ever decreasing evidence of benefit, to the extent that I think what you're now telling me is that there's little scientific evidence they produce any benefit, and quite a lot of evidence they produce quite a lot of harm in children.
Yes, sure. There is a good deal of evidence that they can produce harm, but I think a bit of the problem here is the way companies have done the clinical trials. They've been awfully concerned to claim the drugs, as you said, are antidepressant. And this is a complex word. Once you use a word like this means that a lot of doctors instantly say, well, this person's depressed, I should maybe use the drug. If the companies had done clinical trials which had tested the drugs out for producing an emotional numbing, for them making people less anxious, making them, if they had been able, or if they'd done clinical trials that were designed to show the drug had an anxiolytic effect, as opposed to being a good treatment for a group of people who are phobic or possibly obsessively compulsive or whatever, then I think they'd have been able to produce a very clear signal that, yes, this group of drugs, in a proportion of people, not all people, do produce a useful clinical effect. And that would have been the point then when a lot of doctors faced with a young person or older person would have been asked to weigh up the idea about, well, here's a useful clinical thing I can do. It's a bit like giving alcohol, which also produces an anxiolytic effect, but of a slightly different kind. Now, do I want to do this for this person who appears to have this kind of problem, given the risks that are involved, or don't I? Whereas if you have a drug labeled as an antidepressant, it tends to suggest I should be using it, as opposed to before I use it, I should be exercising judgment about whether to use it or not. And the key point behind the paper is that trying to say it isn't the case that we shouldn't use these drugs at all, but we need to have the evidence laid out in a way that will let doctors and patients work out, is this the right thing for them?
Now, you talk in the paper about some other negative effects of these drugs on children in particular. You say the SSRIs can reduce growth velocity and increase weight gain, which certainly the latter problem for a child who's already insecure and unhappy and maybe being bullied, that's a very common reason why children get low, would be deeply problematic. So could you say a bit about this reducing of growth velocity and increasing weight gain, particularly as a side effect that we should worry about with children?
Yes, it's reasonably well known that the ADHD group of drugs will cause young people not to grow as quickly as they would otherwise grow. That's been handled by things like saying when the school term is out, that you should try and give the kids a break from the pills to let their growth catch up. The same kind of reduced growth rates have been found in the clinical trials of the SSRIs, but that hasn't fed through to the wider population. The idea that, maybe we should be looking at this and we should be giving any of the kids we put in these drugs a holiday from the drugs, that isn't a thing that's caught on. Partly perhaps because the companies know that there is a real risk of people who go on these drugs, a proportion of people get hooked to them. And if we were to say to doctors that, look, you should be thinking about the fact that this child may need a holiday from the treatment, that might be the point where doctors and patients begin to say, well, what's going on here? It's awfully hard to get off these drugs. The SSRIs as regards weight gain, when they came on the market first 30 odd years ago, the big hype was these are drugs that cause you to lose weight. And when you go on them for the first few months, people can often lose weight, partly because one of the problems they cause is that you can also become mildly nauseated on them, so you aren't as inclined to eat when you go on them first. But later on, once you've been on them for about half a year or so, broadly speaking, more people gain weight than lose it, and the weight gain can be fairly substantial. And if you aren't able to get off the drugs, then it can become a real problem.
Some of the other side effects you talk about, which I think apply more to adults, you use the term genital numbing. So what is genital numbing?
Well, in the case of everyone that goes on these drugs, within about half an hour to an hour, if you get people to check, they will find that they're genitally numb to some extent. It may be extremely mild, or it may be very marked. They'll say, yes, I'm actually very, very numb. Okay. Now, the usual, and that's true of pretty well all people who go on these pills, certainly 9 out of 10, maybe even more than that. The usual story has been that once you halt the drug, and maybe if you had halted if you're going away for the weekend and you need not to be genitally numb, that things will be fine. And that was, broadly speaking, the kind of message doctors took on board for the drugs who have been used first for adults. But in actual fact, it's now clear that a proportion of people, when they come off these drugs, they can become even more genitally numb after they halt the drug, and they can remain sexually dysfunctional for 10, 20 years afterwards. This is a problem in the sexual domain that's rather like tardive dyskinesia with the antipsychotic group drug, that you can have a mild problem when you're on the drug, and it may only be when you halt the drug that the problem becomes more severe and can endure for ages afterwards.
And the other thing that you mention is a prolonged QT interval. So for the non-technical listeners, what is a prolonged QT interval and why is that important?
Well, you don't need to be technical or non-technical to appreciate this point, which is we don't know what it is. Now, what I mean by that is you can look at a cardiogram tracing and you see parts of the wave of the heart wave that everybody sees when they watch a program like ER, where the person's heart has gone flat and you need to get the crash team in awfully quickly in order to try and get their heart going again. It's that kind of wave. There's a little bit of that that's called the QT interval. And on this group of drugs, what's called the QT interval, this bit of the wave can become longer. It can distort. It can change. The odd thing about all this is one of the things that we can't computerize. We can't put it on your iPhone measure it easily. And even when you see it on the cardiac tracing, people aren't absolutely sure whether things are abnormal or not. We don't actually know what's going on here. The best way to think about it is these drugs, all of them, they all affect the heart. And the QT interval is a thing that's just a tip of the iceberg. It's a hint that these drugs are having an effect on the heart. Now, in its own right, for most people, this isn't a huge problem. If you push the dose of the drugs up very, very high, then you can kill people just being on one antidepressant on its own because of the effect the drugs have on the heart. The biggest problem comes from if you're on an antidepressant and you take an antibiotic that also produces, say, the same kind of changes, or an analgesic, or a range of other drugs that can produce the same kind of problem. If you end up on 2 or 3 drugs, all having a similar effect on the heart, that's when you can run into problems. And it can be the case that you just drop dead out of the blue.
Okay, so you contend in this paper that when you've reviewed 20 trials on the use of antidepressants with children, the results are negative. So what do you mean by that?
By that is, when we do clinical trials, we specify a primary outcome. We say that for us to say this drug has worked, we want to see a change in X or Y or Z, okay? And if we don't see a change in those things, then the drug could do all sorts of other interesting things, but if it hasn't changed the things that the trial's designed to look at, then we're going to say that this is a negative trial. And in the case of the primary outcome of the trials for all of the antidepressants that we have on the market, the drugs have a negative outcome. They can do useful other things. There are things that people have been able to fish out of the clinical trial data and say, well, look, this looks good, don't you think? In actual fact, on the criteria that we've preset saying, look, for a fair test, we have to see a change in these particular parameters here. You can't find it for the antidepressants in this age group.
So to summarize, what you're really saying is that for depression, these drugs shouldn't be prescribed for children.
Not quite. One of the issues here is that a lot of people looking at the data from the antidepressant trials, both in children and adults, say, well, look, this is just a placebo effect. It's all in the mind and things like that. If anyone takes an SSRI, it's a bit like taking alcohol. You're not going to persuade a person who's had a drink of alcohol or who's had an SSRI that the effect of this is all in the mind. It's real. In this age group, I think, is that the companies and the experts who've had input to how the companies design the trials have designed the wrong trials. They've tried to aim for too much. They've tried to aim for things that suit the marketing department, which is we want to say this drug is useful for all people. In actual fact, they could have designed the trials to show that these drugs have a useful anxiolytic effect that's different to alcohol and different to the benzodiazepines and different to the antipsychotics. It doesn't work for all people, but it can work for some people. And as I say, we would have got back to a more nuanced clinical kind of situation where doctors generally, both experts and generalists, would have been in the position of been saying, look, this is the thing these drugs do. They're anxiolytic. You can use this usefully for some of your patients, but not all. Part of the problem is when these drugs came on stream first in the late 80s, early 90s, we had a benzodiazepine crisis. And the whole idea of an anxiolytic group of drugs was tricky for a lot of doctors. They didn't want to think they were giving a drug that was just going to numb people. So it was a convenient message to say, well, no, this is an antidepressant. It's not an anxiolytic drug, and it's going to cure the underlying problem. But these drugs are not specifically antidepressants. They aren't as good as the older drugs we had. They don't get people who are severely depressed well. And the other thing is they don't suit all people.
Now, at the end of the paper, you talk about some conflicts of interest, because all authors these days in academic papers have to declare that. And you talk about, you and one of the co-authors have been expert witnesses for plaintiffs in legal cases involving SSRI harms. So tell us a bit about that.
Yes, well, the SSRI group of drugs have been linked to people going on to commit suicide, have been linked to people homicide, have been linked to people becoming hooked to them. And in the case of the cases that I've been involved in, these haven't actually been cases against other doctors doing the wrong thing. They've been cases against the pharmaceutical companies for the warnings that they've given are not. And the case has usually been about the fact that the company, the risks were than what they told doctors. And that's been what the cases have actually been about. The other thing I should say, though, in all this is that I've been a consultant to most of the companies. So I've been influenced by them to see things from their point of view as well. And in terms of, for instance, the homicides that this group of drugs can cause, I've been involved as an expert in cases where a person has been on a drug and has claimed if they hadn't been on this drug, they wouldn't have gone on to kill the people that they killed. And I've thought they had a good case. And actually, there's a great case as regards to the science that these drugs can do this kind of thing. But equally, I've been involved in cases where I've been asked to actually look at a case and decide, could the drug have caused a problem in this case? Could it have led this man to go on and actually commit homicide? And I said, no. So I'm the best person in lots of ways if you want to show that the drug didn't play a part to ask me in, because while I think the drugs can cause a problem, I've been very clear in cases that I've actually been involved in that in this case that it hasn't caused a problem. There's two things that need to be kept in mind. One is the general case that can be made about these drugs being able to cause a problem, but a different issue is looking at the particular case and trying to decide that just because this drug can cause a person to commit suicide or can cause a person to commit homicide, and the person was on this drug and they went on to commit homicide, doesn't mean that the drug caused it. You have to, there's a clinical case to be made looking at the full details of the person's history, and if you're able to interview them afterwards, trying to work out, well, actually, did the drug cause this problem or not?
So it's been a fascinating paper to read. It's been fascinating talking to you. I'm going to ask you a slightly perhaps unfair question that may lead you to run screaming from the room. But what I find interesting talking to you and about this much more nuanced view you're giving me about how doctors should think about prescribing these kinds of medications is it seems to run a little bit against a growing trend that you see in private practice with insurance companies and also the NHS, that they tend to see psychiatrists in the mental health team as basically people who just prescribe drugs. It's very difficult these days when an insurance company or in the NHS, people are allocating patients to who should see who. They say, do they need a drug? If they need a drug, they'll go and see the psychiatrist. So I'm just getting a slight sense from you that you would maybe, feel free to disagree with me, agree with me that psychiatrists are really there to do a lot more than just prescribe drugs, because it's a more any prescription of a drug is a more nuanced, complicated thing. But again, I wonder what your thoughts are.
Yes, I think this is a key thing. I think if we just get seen as the people who hand out the pills, we risk going out of business. We're paid well, and if it's just a case of giving out pills that work well and are free of problems, then nurses are going to be cheaper than we are. Pharmacists are actually going to be cheaper. And in the United States, clinical psychologists are going to be cheaper prescribers than us. I think we need to recognize that the drugs can work, but they aren't always helpful, that they certainly come with problems. And if you're going to pay the kind of money that we get paid, it has to be on the back of it needs judgment to know when to use these pills or not. So if we just become the people who routinely hand out pills, I think we aren't going to be in a job for long.
But that's exactly what's happening, isn't it? People are making the decision for us. They send us patients because they decided the patient needs the drug. Yes. And I think what we need to do is we need to push back. We need to say, look, part of what we're trained to do is to know when not to use pills. And we do more than just giving pills. And when we try to say that, the question comes back, what is this other thing that you do? Because in private practice, I'm constantly fighting battles with insurance companies over that point. And in the NHS, I mean, it's a slightly different problem in the sense that people are overwhelmed in the NHS with a kind of clinical wave of patients coming at them. But there is still a sense in which psychiatrists are in grave danger of being de-skilled in anything else other than prescribing, because they're just being allocated to that job. The decision's being made prior to the patient arriving in the clinic as to what you're meant to do with them.
Yes, and I think we've dug a hole for ourselves here, which is we have let the pharmaceutical companies run the trials where we run them. We have let them sequester the data where the data used to be available. We've let them ghostwrite articles for us when we used to write the articles. And as a result, we've ended up with a literature which says these drugs work wonderfully well and are free of problems. And the insurance companies look at this and say, well, if these drugs work wonderfully well, this is the quick fix, this is the cheap answer to the problems that we're trying to handle. It isn't just a case of saying to the insurance companies, look, we do more than give drugs and we know when not to give drugs. We've undermined ourselves by not ensuring that we have the evidence base to show the insurance companies that using these drugs is tremendously tricky, and it's going to, if they're going to see the patient, what they're going to get out of it is skill judgment about when to use the pills and when not, or how to use the pills, and other approaches towards the patient than just using pills.
Well, Professor David Healy, it's been wonderful talking to you. The title of the paper we've been discussing is Pediatric Antidepressants, Benefits and Risks. It's the authors are David Healy, Joanna Lunuri, and John Giardini. Professor David Healy is Professor of Psychiatry at the University of Bangor in Wales, and the paper is published in the International Journal of Risk and Safety in Medicine. Professor David Healy, thank you very much indeed.
Raj, it's been great talking to you.